great to see all of you here. I'm delighted to welcome you to today's Medical Center Hour. This is also UVA's 2019 Alpha Omega Alpha Lecture, sponsored by the Medical Student Honor Society, AOA. In addition, this particular venue on this particular day, as many of you know, is part of our fourth-year medical students residency readiness course. 2 weeks of practical prep for the intensive medical and surgical specialty training that the newly minted MDs from the class of 2019 will start this summer. Residency readiness includes a focus on leadership. So what a lovely and powerful coincidence that our AOA visiting professor is herself a distinguished leader in medicine with leadership experience across the full spectrum of the profession. And what a coincidence and a joy that she's here to talk with us, and especially with members of the class of 2019 about leadership in medicine 2020 and beyond. What will doctors be? Dr. Christine Cassel is Presidential Chair and Visiting Professor this year at the University of California at San Francisco, where she's working on projects in aging and longevity, technology and healthcare, and biomedical ethics. She is a geriatrician and a biomedical ethicist by training, and an expert in health policy and quality of care. But over an influential career spanning decades, she spends so much more. Most recently, she led the American Board of Internal Medicine and its foundation, was president and CEO of the National Quality Forum, and served as planning dean for the new Kaiser Permanente Medical School in Pasadena, California. She's also been, along the way, a department chair, a medical school dean, a medical specialty society president, a presidential science and technology advisor, a member of the National Academy of Medicine, and a board member for many foundations and organizations, and also a champion for physicians' social responsibility. You'll find a thumbnail summary of her career and accomplishments in your handout. Even as UVA and other medical schools prepare to graduate a new wave of physicians, we find ourselves speculating about these new doctors' place and possibilities in a healthcare system that's set by tremendous organizational, sociocultural, political, and financial pressures. We welcome Dr. Cassel's perspectives on what should be expected of you, young physicians, as leaders in your practice, in your communities, in government and policy circles, and in the public square. What will you, new doctors, be? Let me quickly say that Dr. Cassel has no financial conflicts of interest to disclose, and also that because the fourth-year students need to progress to their next class session by 1 o'clock, we're going to aim to wrap up the formal presentation and a couple of questions by 12:50. And so we'll pack a lot into this, not quite an hour. So all of you, please join me in welcoming Dr. Christine Cassel.
Thank you, Marcia, and thank you everyone for being here. This is a great opportunity for me. I always love talking with medical students and future physicians. So you're going to be hearing, I've been thinking a lot about the future of our profession lately. And so the title for this talk might equally be bioethics and what lies ahead. So you might think of it like that. So I'm going to start with a kind of brief reflection on where I've been, and then have us shift our focus and look forward. And I will keep an eye on the clock and very much try to allow us to have some time for questions before folks have to leave. So my story, I was a philosopher before I became a physician. And so it always actually led me to be thinking, sometimes in the background, sometimes more in the foreground, about the role of the physician and the whole idea of being a diagnostician and a healer, and how do values determine the answer to that question. I was a graduate student in philosophy without health insurance, hiking with some friends in the Pacific Northwest, and I fell and broke my arm. I went to just the local community hospital, and they wouldn't let me even sit in the waiting room because I didn't have insurance. My dad had been a Navy officer, so there was a Navy base nearby, so we went there, and I'm like this, my arm hanging. And there was a doctor on duty, and he said, oh yeah, come on in. And I had no right to be there. I wasn't a military officer. I was no longer independent. He took an x-ray. I think he was probably a family physician or a generalist. I know he was an orthopedist. But we got out, this was before the internet, so we got out a book of fractures and looked together. This was before we called it shared decision making. Looked together at the x-ray and said, which one? I think it looks like this one. Well, maybe it's, anyway, it turned out to be a rather unusual fracture inside the elbow capsule. He said it. I went on my way and he asked me to come back. And the foreman said, very upset, Captain, how should I file this? Because it was obviously highly illegal. Without skipping a beat, the man said, file it under H for humanitarian. Well, I fell in love. I said, wow, can people really do this in real life? This is not philosophy. This is like morality in action. And so while I was waiting for my arm to heal, I went to the local library and got out some chemistry books and said, yes, I could probably do this, you know, and one thing led to another, and I applied to medical school and never looked back. It was the best decision I ever made. I only wish I could remember that guy's name and find him and thank him. Well, so as I came into medicine and training and then in my fellowships, I decided to try to work in this field of ethics and actually to try to identify ways that as a clinician and as an academic, I could apply philosophy to medicine. And in those days, doctors and nurses were just beginning to talk about ethics, and there were barriers. Most clinicians thought ethics and morality were private. You didn't talk about them. And medicine is scientific and objective, and there was a big sort of gap. And yet, all around us, there were moral questions and challenges of the day, like end-of-life decisions, reproductive choices, distribution of organs for transplant, allocation of limited ICU beds, many of them still very familiar. And at the time, there was this new discussion that was happening between legal scholars, philosophers, and doctors and nurses and other clinicians. Now, it is true, people do have personal religious and moral views, and this is exactly the reason why in our society, especially a multicultural society, we need a language and a dialogue to deliberate about these difficult questions that inevitably come up and are going to continue to come up. We need not only to discuss the issues, to disagree, to explore those disagreements or deliberate. We also, because it's medicine, we also need to decide. And we need to make the bioethics as a scholarly discipline and clinical specialties come together at this moment of decision, the weighing of the pros and cons, different perspectives, making a decision in a clear sense, even when there's disagreement, that everyone was heard, this is what we're going to do, and most important, this is why we're making this decision. Now, lots of these decisions are made at the bedside, or in the clinic, or in one-to-one interactions with patients, kind of like that military physician who inspired me to go to medical school. And we've gotten better at a lot of these things. like learning and respecting patients' views, advanced directives, setting up a national system for distribution of transplantable organs, establishing guidelines for informed consent and research with human subjects. All of that is progress. And another kind of progress has also occurred 20 years ago. In 1999 and 2002, the Institute of Medicine published 2 eras, Human and Crossing the Quality Chasm. I was a member of the committees that wrote those reports. In 2002, the ABIM Foundation published the Physician Charter on Professionalism, and I was with the ABIM at that point. These documents, all of them just about 20 years ago, laid out a clear and urgent sense to strengthen other aspects of professional responsibility, like being a part of a system of care, making quality and safety data transparent, improving quality and safety, not just for the patients in front of you, but to avoid errors that might happen to other patients. The charter demanded of us to improve access to care and to be thoughtful stewards of resources for patients and society. Now, some issues in biomedical ethics, like reproductive choices, will continue to be debated. Some issues, like medical aid in dying, or what we used to call physician-assisted suicide, we once had a social consensus about this. And that consensus is now changing. 8 states have now legalized some form of medical aid in dying. California did this just last year, the huge and diverse state of California. Now, the fact that the laws have changed in those states doesn't change the fact that people will continue to disagree, people will continue to be troubled, and yet it creates a new social and legal construct in which that discussion needs to continue. So some of these perennial questions, my point is some of these perennial questions will continue to be asked, but there are also going to be new ones. There's new scientific knowledge, new capabilities that we have, new technology, and changing social and economic landscapes that continue to challenge us. So physicians will need to have the skills to deal with ethical issues that we can't even imagine. Certainly that we can't predict. So what I want to do with you today is to identify some of these future questions, and in the process of that, think with you about the future practice of medicine and what your lives and your professional work might look like. And in doing this, I want to sort of turn our attention from the past to the future when all of you are actually going to be practicing. So I got to thinking about this very intensely about 3 years ago when I had the opportunity to join the efforts of a huge delivery system, Kaiser Permanente, to start their own new medical school. My role was planning teams, so it was all about setting the stage, doing all the sort of background work to get it set up. The concept here, the KPSOM as we called it, Kaiser Permanente School of Medicine, is not affiliated with the university. It's a medical school based, embedded in a healthcare delivery system. The only other medical school like that in the United States is the Mayo Clinic. And they did that 40 years ago, but for many of the same reasons, wanting to train doctors in a whole cultural different way of having specialists interact and information flow around the patient. So here we are now 40 years later, and Kaiser has this amazing system of care that has been 70 years of a prepaid model. What the rest of American healthcare is trying to aspire to value-based purchasing. Kaiser's been doing this for 70 years. It's full of data because they have an enrolled population, so they have all, and they were early to adopt electronic records, so they have a rich database. And their members, and a lot of trust and retention of the members. So they have really good longitudinal data, and much of it actually genetic at this point. The physicians practice with real-time visibility of their own quality and safety metrics, as well as comparative data across the whole system. They work in teams. They're driven by this primary care model where primary care physicians are really at the center and really respected by the specialists and everyone in the system. They focus early on intervening in patients' care, close communication and coordination with specialists, and a very strong relationship with the community, because if you can intervene upstream, you can reduce the cost of care. You can reduce unnecessary hospitalizations and emergency visits. So what I did there was I helped to create a new legal framework for the school and to recruit the founding board of directors. This board included leaders in medical education, of course, but also leaders in innovative technology. Two in particular, Anne Wojcicki, who is the creator and CEO of 23andMe, one of the online genetic mapping organizations, and Peter Lee, who's the executive vice president of Microsoft, in charge of innovation. Would you love that title? Innovation, for all of Microsoft. He's got this amazing sandbox at the moment, just imagine. Anyway, the two of them asked me, why would you want us to be on the board of a medical school? We don't know anything about medical education. This is what I told them. I said, do this thought experiment. The first class will start in 2020, next year. In 2024, they graduate. Then they do a residency for 3 to 5 years. So our challenge is to figure out how to prepare physicians to practice for 2030 and beyond. So remember now, we're in California, so it's that Silicon Valley world. People know that, Google started barely 20 years ago. Facebook only really got started 10 years ago. What is going to be the next thing 10 years from now? We really, I think, have no way of knowing what technology changes, but also what social changes are likely to occur. So, by the way, both Anne and Peter signed on enthusiastically and have been very effective board members. And they ask a lot of really important questions about the future. One of the most important things they point out is that we won't know exactly what the changes are going to be. The one thing we can be sure of is there will be change. And the question is, are we preparing our students for change? So, more on that. But it leads to this title, what will the doctors be and what will be their role in health and illness? What will be their role as citizens and what will they be doing every day 10 years from now? So, while I'm talking a lot about change, I want to sort of express my hope, one constant that I think we should strive for, which is that I hope that doctors continue to be trusted professionals, even though our role and how we work may change. If anything, there's going to be an even greater need for trust in the humane interface, if you want to think about it that way, of science, of humanism and health and the relief of suffering with science. And that's going to continue, and it's going to be up to us. It's going to be up to you to navigate these changes and to make that fundamental value endure. So here's a few of the changes that I've learned to think about, and I'll bet the people in this room have a lot of ideas about others as well. So the first, which is of course already upon us, is organized systems of care physicians are practicing in groups in larger organizations. There's lots of data about this. And it's not just about controllable lifestyle models, which, as important as that is, it's also because we've learned that that's really a system of care around a patient, is what you delivers better care for that patient. The second thing is the growing roles of other disciplines, and in particular, nurses who increasingly are working in independent practice settings and in larger teams in different kinds of relationships with medicine. Pharmacists, you don't probably think as much about that, but this whole model of retail clinics is allowing I think one of the most underutilized areas of expertise, the pharmacist, to come out from behind the counter and become part of the team. As a geriatrician, I can tell you that the medication interactions, and now we're going to have pharmacogenetics, which is going to be essential to prescribing and reducing those medication adverse events. There's no way any physician or advanced practice nurse is going to be able to understand that, even with the best decision support at your fingertips. So the pharmacist, I think, is going to be a key, new, emerging, strong force. All of these folks are going to be practicing at what we now call top of license. So that's a really important use of a limited resource, which is the medical workforce, the healthcare workforce. But what does it mean about physicians? What does it mean to practice at the top of your license if you're a physician? I think one of the things we say very easily, that physicians are going to be involved in the most complex issues, the most complex cases, maybe as leaders of complex systems of care. And, I welcome sort of your thoughts about that too. So, I mentioned decision support. The other big change on the horizon is artificial intelligence and machine learning. That's an area I'm working on while I'm at UCSF now. In Silicon Valley, some of the futurists there are predicting that we won't need doctors in 30 years because artificial intelligence will be so smart that people will be just able to go online, put in their symptoms, and get their prescriptions, and there'll be maybe surgeons. There'll be still some work for surgeons, but certainly any analytical diagnostic care can be delegated to an algorithm. Well, I don't think doctors are going to be obsolete in 2030, but I do think we have to think very carefully about how are we going to interface with artificial intelligence. There's already published reports that AI outperforms radiologists and pathologists in a number of common diagnostic areas. Retinal scanning, they get much better diagnostic accuracy from artificial intelligence and machine learning models. These areas are all image recognition, and that's kind of low-hanging fruit for AI, but radiologists themselves acknowledge, I'm not going to ask who's going into radiology here, but some people predict we won't need radiology anymore. Radiologists themselves acknowledge that there's going to be dramatic changes in the role of radiologists, not in 10 or 20 years, but in 3 to 5 years from now. So I think in general, we need to anticipate dramatic changes in how we interact with information, how we interact with information systems, also how it shapes specialty practice, and how consumers access this very same information. So that's the other thing, consumers. Even right now, people who are uncertain about whether they really need to go to the doctor or go to the emergency room can go online to one of a half a dozen different chat services that are free, similar to advice nurses, that will check your symptoms, let you know what the most likely diagnosis is, and refer you sometimes to the most appropriate types of care. There's all kinds of new apps that are offering to do this. There was medical expertise in developing the content and often the people who created the companies, but the voice that interacts online is not a human being. It's an artificial intelligence that's very smart and even can joke about it. And there's one of them that says, "Hi, I'm a bot, how can I help you?" So, and people are getting more and more used to this, and it's kind of, a game that they play. So this kind of information can also be used to extend what we think of as telemedicine. So sometimes, there is a physician there at the other end, and many health systems are now investing in this because it's a much more efficient way to deliver care. I know that that's happening at KP, and I suspect that you're doing some of that as well in rural areas of the state. So these new innovations are already upon us. There's real questions about the quality of the information in all of them, but it's getting better, and who's to say, and how are there going to be ratings of the quality? Is it going to go by Yelp? Is it going to go by, the FDA going to regulate these things? All of that remains to be seen. But a question for you is, what is your day going to look like? And what is the work that you're going to do? How is it going to have the greatest impact on the greatest number of patients? And how, in the process of that, can you maintain that humanity at the center of this profession? So, as we watch these new products enter the market, and widely get adopted by consumers, employers, and others, it's clear that a lot more are going to emerge. So, in doing this, we free up physicians, nurses, psychologists, psychiatrists, and people who really are scarce to spend their time on like the 20% of people who really need that face-to-face interaction, that more complex interaction, or who for one reason or another don't have access to or aren't comfortable with the online interaction. So it's going to dramatically reduce the traditional hospital base, and by the way, has lots of challenges for our current payment models, and I'm not really going to address that here. But in some ways, that's why many of these innovations have already been widely adopted in many European countries, because they have global budgets for their healthcare system, and they have to deliver care within a defined budget. And this is a much more effective and less costly way of providing care. All right, switch gears for a minute. Genetic information, I mentioned 23andMe, there's also Ancestry.com, and now millions of people have gone online and gotten both their ancestry information and in many cases their medical information in various kinds of forms. Some of it is even FDA approved now. So what does that mean? It means more and more patients are going to the internet and then coming to your office with questions about the significance of these gene variants. Well, I don't know about you, but as a general internist and geriatrician, no matter how well trained, physicians are not geneticists and are not specialists and are not going to be comfortable answering these questions. So you could do what my doctor did and sit down together and Google the results and see what you could learn together and figure it out. Or you can find other ways to direct the patient. Maybe there will be a new specialty that will emerge about how to interpret these things. But one of the most important things is that it's no longer just academic interest, because many of these disorders now can be treated. Alzheimer's disease, one of the hugest challenges. We still don't have a good treatment, but there's more and more reason to think that whatever treatment, when that does finally come on the market, you'll want to start it as early as possible. So wouldn't you want to know if you had some genetic predisposition? But there's also gene editing. So this just within the last 5 years, and Jennifer Doudna is at the University of California, so we actually have some interaction with her and her team there. She's the one who discovered this model or created it. So you probably heard recently about this Chinese physician who used gene editing to create these actually twins, not one baby, but two, under some people feel a sort of spurious idea that they would then be immune to AIDS going forward. He did this in the middle of a pretty global scientific consensus that there needs to be a moratorium on using gene editing at this stage of the game in the germline. There's lots of gene editing research going on that's really fantastic about various other kinds of illnesses. But there's this fundamental queasiness, I think, about the idea of making heritable changes in the genome, because people have kind of deep moral qualms about the nature of human identity, and well, they should, and well, we should be discussing this. But, what if you could end sickle cell disease forever? What if you could end Huntington's chorea or Tay-Sachs? What price would be worth paying? And what risks would be worth taking? And who decides? In 5 years, not 10 or 20, I think, these questions could be in front of you to figure out whether they should be offered to your patients. So those are just a few in science and technology, but there's also changes before us outside of biomedicine and technology, changes in our society. Most dramatic is a gap between the rich and the poor that is forever increasing, has been growing for the past 30 years and is getting worse. While our economy is growing, the top 10%, particularly the top 1% of people are increasingly doing better, and everybody else is doing worse. As citizens, we should be concerned about the social and political instability this creates, but for healthcare, it creates a fundamental challenge as our costs continue to increase, continue to be unaffordable for people, and continue to prevent wages from rising because healthcare costs by employers are so enormous. And then the other thing that lies ahead is that baby boomers are going to double in the next 20 years. People are living longer. That's a good thing. Is it a boom for geriatricians? Maybe. But one thing that we don't talk about, many people even talk about this all the time, we don't talk about 40% of people now over the age of 65 and coming into the baby boom have zero savings and zero pension, meaning they are going to be completely dependent on very small Social Security payments if that persists. So even Medicare has high out-of-pocket costs. So what we're going to be seeing is working people and elders alike, patients who are extremely poor. And meanwhile, biomedical science will continue to advance, and there will be dramatically effective new drugs and other treatments, many unaffordable by a majority of people. And these economic and social disparities result directly in health disparities that we now call social determinants of health. What is our role in addressing these issues as physicians? How does medical ethics help address these questions? What can you, the students of 2019 and 2020, be doing in this world that lies ahead of us? So some of you will develop innovative approaches to using technology to improve quality and access. Others may take inspiration from Virchow, the 19th century pathologist who told us politics is medicine writ large. He was a doctor, but he went into political life and got himself elected as a legislator in Austria because he saw that poverty was such, even then, that poverty was such a driving cause of illness. And some notable physicians in the United States have taken both routes, actually, the scientific search for answers and the social political search. Health is about social and political issues, so bioethics has to be there too. So at the Kaiser Permanente School of Medicine, how did we think about future-proofing the curriculum in a way? We did adopt some new technologies, holographic ways of teaching anatomy, and integration of AI and machine learning into the curriculum on diagnosis and those kinds of things. But most important, in addition, a deep core of teaching on ethics. But in addition, probably the most important thing was leadership skills, including change management. We can't anticipate every change that's ahead over the course of the next 10 to 20 years, certainly over the course of your careers. But we can equip you to understand change, to be ahead of it, on top of it, not victims of it. Perhaps even agents of some of the changes that we would like to see. So I want to close now because I want to leave some time for your thoughts and questions. But in doing that, I want to repeat the thought to leave with you. Whatever lies ahead, I hope that doctors will continue to be the trusted professionals, even though the definition and the role may change. That need, the need for trust, is in the interface of all of this science that's going on around us, all of the questions that it raises, all of the social disruption and change that we've witnessed in the last decade especially, and I'm sure we're going to be seeing ahead of us. But health problems and suffering are part of the human condition, and we have unique tools that can help people in those situations. And if their definition of our profession is going to be sustained and going to be something more than just a vendor online, then it's going to be up to us to navigate those changes, to make sure that that essential trust survives. Thank you, and I hope to get some ideas and challenges from this fabulous audience. Thanks very much.
Thank you so much, and we have a few minutes for some comments and questions. We'll have a couple of mics, one here and one in that aisle, to take your comments and questions. And I'd like to start with right next to me here. Please identify yourself.
So Lee Webb, I think most of you know me. I'm one of the co-directors of the leadership curriculum here. So Dr. Cassel, thank you so much, first of all, for being here today. I thought this talk was very informative, especially about how we should think about the future. And I'm seeing a few themes there, two of them being the ability to manage ambiguity, and another one being sort of leadership agility in a sense, in addition to change management and some of the other things that you mentioned. I guess my question is, from a practical sense, like a lot of these students are going off to residency and to do some other things after medical school, how do you keep up? If we're trying to, sort of, residency for me was a vacuum. I was just trying to keep up learning about my patients and trying to do some self-care. I probably failed on that front, but like, how do you keep up with some of these future innovations in a practical sense for you? And
so this is keep up with what's happening in
in
science.
the world around you, like what are
Like the world.
in the world around you, like how do you keep up when you're resident? And even beyond that, as physicians, we like work a lot. We're trying to take care of our patients. Maybe we're reading journal articles specifically about sort of patient care. But are there resources out there that can help us just keep up with what's going on outside?
Well, I'm not going to recommend a single. That's a really good question, because I'm not going to recommend a single resource. I think the bottom line is, and you've all heard these things, that something like 17,000 new articles and clinical trials are released every month, and there's just no way you could possibly keep in touch with all of that. So that's where AI ML is really going to be our friend in better and better ways all the time. And you're already seeing that from the NIH websites and some other places. I think one of the, since consumers and physicians are going to have access to the same information, I think there is going to be more of a level playing field. And one of the things we can do is help to curate and identify which of those information sources are really reliable and really the highest quality. But I think that's going to be a great source of help. I think the other thing is that since I made the point that health is also political, and we live in this very, echo chamber of noise about political perspectives and points of view and proposals, to think about a way of streamlining your attention if you're, if you want to pay attention to that stuff, and I think on some level we sort of have to, we have to find ways of cutting through the noise and really paying attention to what matters. I find personally that sometimes the most trusted sources, two things. One is some of our specialty societies continue to really advance and provide that service. So for me, the American College of Physicians, for example, is a good example of that. But I think people are going to find their own way through it. But I think the most important thing maybe is to be conscious of the fact that you need to do that, and that some of the old ways of doing it aren't going to be as effective.
Other questions, comments?
Here's one right here.
Oh, all right.
And also anything I missed that I should add to this list.
Hi, thank you so much for coming. I thought this was a great talk as well. It's kind of a bunch of central themes, but with the emergence of AI and these healthcare innovations, there's kind of an entrance of new players into the healthcare system. And I think one of the unique things about these players is we don't have the same knowledge base. Like when you're talking about pharmacy, you're talking about other specialties, we can somewhat, nursing, you can somewhat have the same conversation. But with the healthcare innovations, you're literally just like fish out of water, have no idea what's going on. If we're trying to do this in an evidence-based way, so we're actually only introducing innovations that are good, how do you recommend we do that? I think with healthcare, it's usually regulation, but how do we regulate something we don't understand?
Well, the FDA is asking itself that question right now. And so I think there was a discussion that even the electronic health record could be categorized as a medical device and needed to be approved by the FDA. They decided not to take that on. But I think I think there is a role for regulation here, actually. But in the absence of that, we don't have that now. We live in a society where people don't want regulation. But here's I think sometimes it's a good thing. I think some private sector organizations can do rating systems and sort of can say, these have legitimate purposes, and I know that some of them are starting, to try to do that, and I think that would be helpful. But I think for just in terms of even the previous question, the same thing is we just have to be alert to this. It means to be, it's kind of like diagnostic uncertainty. You need to not be chasing zebras all the time, but always keep that thing in mind. That headache might be meningitis. It's probably not, but just, So same thing with this, you just be suspicious, but don't cut it off. We need to use these tools, but we need to have a healthy skepticism about them.
It just occurred to me, we don't usually work in this room with Medical Center Hour, but you all have mics. And for those who are accustomed to being in this room, you need to press the button to make it go, but raise your hand and use your mic.
There's one.
Please tell us who you are.
I'm Dr. Baldwin from Lynchburg, and I've been interested in low socioeconomic communities who don't have any doctors. And I'm wondering if you've run into the idea that we need doctors on salaries, some sort of a way to get doctors into these communities and to establish the relationships it takes to be an effective physician. And in our free enterprise situation now, our doctors and hospitals are moving towards the paying patients. You mentioned 40% of people over 65 won't have the funds to address that. I don't see any other way than to have doctors on salaries.
Yeah,
And
well, and I think by doctors on salaries, so the question is, are we going to, that was kind of, I went over it very quickly, but the first point about doctors being part of large organizations, and I think we're going to see more and more of that because the fee-for-service model just doesn't work to try to get the most efficient systems of care, where you spread the care among all the care providers, and you get nurses on the front lines, and you use telemedicine, or you use email, or you use, video conferencing to get to those very remote. We have a wonderful program called Project Echo that started in New Mexico that gets care in very rural parts of this very big western state entirely remotely and very effectively. But it only works because the doctors are on salary, because otherwise you can't bill for this kind of service, right? And there's a whole lot of other reasons why I think that's a good idea. If you look at the data on quality of care, the systems of care in which the physicians are salaried actually have always consistently produced the better outcomes overall for patients. So I think it's a model that we're headed towards as a country, and I think it'll also help, along with a lot of other things that we need to do to really address the combined challenge of rural and poverty that faces so much of our country.
Another question?
There's one in
There's one in the back, yeah.
Yeah, I'm curious about what role you think that medical professionals should play in deciding the kind of the rules that govern innovation. Simply because of the financial interest that the professions have in the system, as it currently stands, I wonder if that gets in the way of innovation.
That you mean sort of a vested interest in the status quo?
Exactly.
Yeah. I think it does. I mean, I'll give you some really good, like, real-time examples. Is telemedicine, which to my mind is a very early first step, is the one-on-one where you still have the doctor or the nurse practitioner on the screen and the patient on the other end. Very effective in delivering all kinds of care, including now increasingly mental health for certain, it's very much needed. And many states have opposed it, not the legislatures, but the medical society of the state, because they see it as a threat to their model of practice. So that's what, to me, is a real challenge of professionalism, that, to rise above whatever your current financial arrangements are, and figure out, as this gentleman down here said, let's change how we get paid so we can not stand in the way of this kind of innovation. And I think physicians traditionally have not been trained to think. That's why I'm talking about thinking more about ourselves as change agents, because the physicians, they think they're doing the right thing. They think they're protecting their way of life and their way of taking care of their patients. But they're not looking beyond that. And that's what I think we're going to need to do in the future. Yeah.
Go ahead.
Yes, Krista Kennedy, fourth year medical student. I'm just curious how you can speak about issues like financial compensation of physicians and vested interests when you were forced to resign from your $200,000+ annual salary from Kaiser Permanente's board while you were chief executive of the National Quality Forum, and while you also took down a $1.2 million annual salary from the American Board of Internal Medicine while they were increasing rates for maintenance and certification.
So here's an example of where what you learn online isn't always true. I never got a $1.2 million salary from the American Board of Internal Medicine. So, you know, I know that that stuff is out there because a lot of people are concerned about the burdens of maintenance of certification, and I'm sympathetic about those burdens. But I think it's really important to look at, as one of the previous people said, to look at the sources of the information and where it's coming from and what the motivation is around that.
Those are coming from 990 federal filings from the American Board of Internal Medicine.
But it's a longer discussion, but those numbers were not my salary. They were represented from a lot of other sources. So, you know, I'd be happy to talk with you one-on-one about that because I think it's important. But I think here's the most important thing about it, is that the maintenance of certification debate has been a real crisis of professionalism because physicians have been really inundated with requirements for all kinds of reporting and public scrutiny, and the board certification is a big part of that. I'm actually now chairing a committee for the National Academy of Medicine about the burnout problem in not just the medical profession, but in nursing and pharmacy and the other professions as well. So I and the ABIM were and are very aware of the need to make those requirements more aligned with what all the other requirements are and reduce the actual work time that's involved. I think actually AI is a tool that we can use to help us with that. But it doesn't mean that but it's kind of like the doctors in Texas who don't want to have telemedicine. We can't just keep moving forward without acknowledging the responsibility of our profession to be more transparent with the public. And the ABIM is of the profession, but for the public. So that information about the quality of physicians needs to be out there, and they need to, we all need to do what it takes to make sure that that information is up to date, that's accurate, and that you know, whatever the technology is that puts the information out there, that costs money, some of it, and that's, you know, every profession has a version of that, and so, you know, if you're a plumber, you spend $2,000 every 5 years to get re-licensed or certified as a plumber. So shouldn't a physician have some similar capacity? And because it's medicine, it's much more complex. So let me just say that, and I do appreciate the challenge because I think that's another thing that we have to be aware of in our field is with growing transparency and the ubiquity of internet information, these echo chambers can develop, and information that isn't entirely true or that is misinterpreted can get then used for other purposes. And we need to be constantly, I think, standing back and saying, what does, you know, the profession require of us and of me? And what's the best thing for the public, which at the end of the day is the definition of professionalism.
So I'd like to thank you again and thank all of you for being here with us today. Thank all of the other folks who've come for this Medical Center Hour. I just want to let you know that this is the last Medical Center Hour of 2018-2019. We'll be back with a series of programs starting in September. Thank you all so much. And, thank you.